So good morning, everyone. Good morning. I'm allowed to give this talk on patient positioning, lateral decubitus, and the beach chair position. So this was 2 years ago as a fellow in Nice. Had a great time, great teachers. Thank you to Audrey, Professor Boileau, and Julie, of course, allowing me to assist in the course and giving this talk. So now I'm a shoulder surgeon in Dordrecht in the Netherlands. Great Dutch pronunciation of the name. Not as tropical as Nice, only 13 hours away, but we do have some tropical animals here once in a while in front of our hospital. So, positioning the patient, lateral decubitus, so on the side, on the contralateral side to be operated on, the beach chair position, and then finally the lazy beach chair position, which might be not as well known. So, in summary, each position has advantages and disadvantages. Almost every procedure can be performed in any position. And in my experience, while visiting some of the bigger names in shoulder surgery, it is the personal preference of the surgeon that decides the position, which is obviously often based on surgical training. So, in general, lateral decubitus performed by lying on the side with traction on the arm improves visualization of the anterior and posterior labrum when you look intra-articularly. There's a limited risk of cerebral desaturation events because the head is not elevated above the level of the heart. And there's a different orientation in anatomy, which you have to take into account. Then the beach chair position, which can be performed with a pneumatic arm device or with traction or no traction. This is with limited stress on the brachial plexus compared to when it's performed with traction. You have an increased glenohumeral and subacromial visualization. There's more flexibility for the anesthesiologist. And there's an easier conversion to an open procedure because you can access the shoulder anterior. So I built up this presentation and ask you to remind the following papers if you want to look it up. These papers clearly describe the pros and cons of both the lateral decubitus and the beach chair positioning and have nice pictures and graphs on how to position not only the patient, but also the staff around the operating room. So lateral decubitus. Here you see that a right shoulder is draped and prepped, and the patient is lying on the left side. And you can see how you can position everything ideally in the operating room. And what is important is that the patient is stable, obviously. So you can use a bean bag and the safety belt. And caution has to be paid to make sure that there are no pressure points around the body, particularly not on the nervous systems. So pay attention to the pressure points and then apply the traction to the arm. And if you look from the head position of the patient, you see that the patient is slightly tilted backwards in order to make the glenoid face parallel to the floor. Also, attention is paid to padding the opposite arm on which the patient is lying. And below you see the images intra-articularly, which you see when you enter the scope. And you can see that the glenoid is parallel to the floor and the humeral head is positioned above the glenoid. And then an important landmark of the biceps, of course, the long head of the biceps tendon, which attaches on the superior side. This is different from when you do it in beach chair position, which I will show shortly. So important things to remember. Good visualization, particularly of the anterior and posterior labral complex, but there's a known risk of neuropraxia when you apply traction to the arm. So never go over 4 to 5 kilograms of traction to the arm, as you can cause stress on the brachial plexus. Then the beach chair position, named after the position we assumedly take when we're sitting on the beach on a chair. Here you see a left shoulder being prepared and draped, and the patient's arm is positioned on a pneumatic device. This is not necessarily the same as traction, but it can apply some traction to the arm. All the instruments and the ventilator machine, arthroscopy tower are more or less positioned in the same way. But you can see that the anatomy orientation is different. So now the glenoid is vertical, the humeral head is on the right side, and you see again the long end of the biceps tendon attaching on the superior part of the glenoid. So this is contrary to the lateral decubitus, where the glenoid is orientated differently. Very important when sitting the patient up is to do this staged, because in collaboration with your anesthesiologist. And this has to do with one of the biggest possible pitfalls of this type of surgery and position, which is cerebral hypoperfusion, which has been demonstrated in patients when you bring the level of the head above the level of the heart in the beach chair positioning. And this is very important. It has been shown that if you have a staged approach, so not put the patient straight up immediately, this decreases the risk of these kind of events. So what then about the lazy beach chair? Well, something I was taught during my fellowship in Nice. You see the great blue chairs here on the Boulevard d'Anglais. And somewhat this always reminds me of this position. So the patient is supine, but slightly placed upwards with the back. So the head is a little bit above the level of the heart, but by far not as much as when the patient is sitting straight up. And you can see the arm is now parallel to the floor and it rests on a pneumatic device. And this is also a technique you can use without applying any traction to the arm. So what does the literature tell us about this when I say it's mostly surgical preference? Well, there are data, of course. So looking at anterior shoulder stabilization, we know that the risk of recurrence is higher when you put the patient in the beach chair position, contrary to lateral decubitus. We know patient satisfaction is higher when we put the patient lateral decubitus when it comes to posterior stabilization, but there's no difference in risk of recurrence. But we also know that if you put the patient in beach chair, usually there are more papers concerning this topic in anesthesiology journals. We know that there are risk factors for cerebral desaturation events, and even cases described where patients unfortunately passed away because of the hypoperfusion of the brain. But if you use a staged approach in putting the patient upward, it does decrease the risk of these kind of events. So then what do I do after I've seen the big surgeons operate and learned from them? I combine the two techniques. So I use the lazy French beach chair for my rotator cuff repair, the treatment of biceps and AC joint pathology, and of course for the arthroplasty, because you have better access to the anterior part of the shoulder where you do the open surgery. But I do use the lateral decubitus position. And I do an arthroscopic stabilization with or without a bone block of the distal clavicle to do my Bankert repair. And the reason for this is that I find it easier to work in the front of the shoulder when I'm able to stand at the head of the patient. It's more ergonomically for me, and it's, I think, easier accessible. And then there's, of course, when you're a young surgeon and you start in a new environment, there are more factors you need to take into account. And one of these is the fact that if you have a new anesthesiology team and you need to teach them and learn them how you want to do the surgery, one of the battles you face is the battle of the blood pressure of the patient. Because in the beach chair position, it can be a struggle to keep the blood pressure on the lower side, which enables you to do a pleasant arthroscopy instead of having no visualization when you hit a vessel. So sometimes I try to cope with this by moving around the factors I cannot really influence and only take into account the factors I can influence. So this is my approach I've used so far when it comes to my procedures. So in summary, each position has advantages and disadvantages. I think almost every procedure can be performed in any position and is mostly based on personal preference of the surgeon, which is again, of course, based on surgical training and fellowships. So thank you very much. I'm more than happy to welcome any questions if there are any. Thank you.